So good afternoon. It's almost afternoon, and I'm happy some of the people have left this hall and gone away. So, the question here really is not defining value in a low resource setting. There's a question I'm asking myself: what am I doing here? After all these masterful speakers and great researchers, I don't know what a simple thoracic surgeon is really doing here. But as Bhavna said, she likes to challenge me, so I'm challenging you guys as well. I hope you can get a gist of what I'm trying to say. So we will talk about defining value in a low resource setting because that is the theme of this meeting, choosing wisely. And this is the outline of today's talk. I have no disclosures. So we all know from the previous speakers, as well as from day-to-day life of treating our cancer patients, that cancer care is really expensive. We are very excited about the new innovations that come with the cancer treatment every day in personalized medicine, in robotic surgery, like Dr. Ramesh said. But all these costs are transferred on to the patients. And definitely there is overutilization of the new treatments that are coming along. We have to also remember that most of the costs are concentrated in advanced stages and in the last year of life. So we can't talk about value without talking about financial toxicity. And this is the unintended, but not unnecessarily unanticipated objective financial burden and the subjective financial distress that our cancer patients go through as a result of their treatment. And this has nicely been put together in a paper in 2018, where they talked about financial toxicity not only being an objective financial burden, but also a subjective financial distress, where the patient not only has to bear the direct and the indirect costs of cancer care, but also has to dip into their savings, sell off the assets, and face financial distress as a part of their cancer treatment. A systematic review of financial toxicity showed us that 28 to 48% of cancer survivors experience financial toxicity when they measured it in monetary measures, but a lot more experienced it while measuring it in subjective measures. And they also found some factors which were associated with increased financial toxicity amongst cancer patients. So coming to the low resource context, how is it different here? How is it similar? Healthcare, as we know, here in the low resource settings in LMICs is variable, fragmented, and unregulated. The government does not spend much on health, even less on cancer care. There is zero to no healthcare insurance, and there is a lot of high out-of-the-pocket expenditure. Most of our patients present in advanced stages. We know they delay seeking treatment. They lack the resources to reach the nearest cancer hospital, which may be hundreds or thousands of kilometers away. And by the time they come to us, they're all in stage 3, stage 4, or beyond help. So a lot of studies in the Indian cancer patients also on financial toxicity, on about costs of cancer treatment, and 3/4 of the patients have reported catastrophic expenditures. A nice paper by Rajpal and colleagues, which looked at distress financing by wealth quintile. They divided the patients into 5 quintiles. The lowest wealth quintile were the patients who were below poverty line, and the highest wealth quintile were patients who had adequate resources to manage their own health. But in every health quintile, in the public as well as in the private sector hospitals, they saw that the patients had to sell off the assets, cut down on their spending on other expenses, and finance their cancer care. They also found that indirect costs were significantly higher than direct costs. So what is value? Coming to the talk, the topic for the talk, value in healthcare. We cannot talk about value without talking about costs, without talking about financial toxicity. And the most agreed upon definition of value in healthcare has been this. It is a measured improvement in a person's health outcome for the cost of achieving that improvement. The goal is to enable the healthcare system to create more value for patients, and descriptions of value-based healthcare, which focus only on cost reduction, are incomplete and erroneous. So NEGM Catalyst actually published this around 5-6 years ago, where they explored the definitions, the benefits, and examples of value-based healthcare. And they said it is a healthcare delivery model in which providers, including hospitals and physicians, are paid based on patient health outcomes. And looking at it, it looks very beneficial to all the stakeholders, the patients, the providers, the payers, the suppliers, and even society as a whole. But it is not the same as measuring cost effectiveness or quality of life. So there are a lot of factors which go in defining value And these may be different in different socioeconomic conditions, in different countries, in different healthcare conditions. But the underlying message is that we need to improve outcomes that matter most to patients. We have to maximize the benefit that we derive from the cancer care while reducing risk, costs, and toxicity. So, value in low resource settings. How do we come about to define value in our setting? Most of the studies that have looked at value based healthcare have been conducted in high income countries, which have totally different healthcare systems, which is more insurance driven. They have better access to healthcare and to interventions. Their definition of costs are different. The waiting times, the travel time, the loss of productivity and wages is very, very different from what we face in the low middle income countries. They also have different measures of financial toxicity. When we look at low resource settings more closely, we know we have competing causes of mortality. Cancer is not at the top of the list for the government or for the public at large. We are still facing a very high maternal child mortality and mortality due to infectious diseases. We don't have the infrastructure. Knowledge is really less. It's not like we have a Tata Memorial Hospital in every city in this country. There are geographic and environmental factors. We know patients travel for 3 days by train to reach the Tata Memorial Center. They have a lot of financial shortages. They sell almost everything they have to get to the cancer hospital. The healthcare service delivery system is suboptimal. A lot of patients have their own social and indigenous beliefs, religious beliefs and practices, which delay their treatment. And of course, like we have already seen from the morning's talks, there are a lot of challenges in conducting research and its considerations. So there have been tools to assess the value of systemic therapy, mainly in cancer. And these are the two tools which have been talked about in the previous by the previous speakers also, the ASCO value framework and the ESMO MCBS. The ESMO value framework is the one which is favored more. It is supposed to be better because it divides the therapies into different classes in the curative as well as the non-curative settings. And these grades are determined depending upon the toxic effects, the overall survival, the disease-free survival, and other parameters. But we have to remember that these tools are complex. It's not something that you can sit and calculate in your outpatient clinic, in a busy outpatient clinic on a day-to-day basis. The ASCO tool is based on assessment of clinical benefit, which could be subjective. And are these really applicable to low resource settings is the question that we need to answer. There's another tool which has been developed as a result of patient-reported outcome measures, the cost measure, and a small study in radiation oncology has been done trying to validate this measure in the Indian population. There are 11 factors which have been associated with financial toxicity, and this is based on the perceptions and reactions to financial distress. But the important part of this study was, of this measure, that they did not include any patients who were uninsured. So this included only uninsured patients, included patients only in advanced stages of cancer. There was no correlation with quality of life. And of course, it has not been validated widely. So value is something that we need to define, something that we will have to find out from our patients, from our healthcare settings, from our conditions. And for this, we need to define the disease process along the entire continuum. We have to focus more heavily on prevention. It's better that people don't get cancer than we go around treating patients in advanced stages of cancer. We have to define our own high-risk groups for screening because we cannot roll out population-based screening in our setting. We have to create awareness and we have to aim for high-quality care, not only at the point when the patient is in the hospital and undergoing treatment, but also later on. We have to identify low-value practices like all the previous speakers have shown in their talks, investigations and treatments which will not change the course of the disease. We have to find help. We have to collaborate, like Dr. Pramesh said in his talk. We have to find experts, and we can do this even in remote settings by setting up virtual tumor boards. And we have to involve, of course, patients and advocacy groups. How do we inch towards this value-based care? We have to incorporate something called health economics in medical training. If you ask me today, I've been in Tata Memorial Center for the last 17 years since I've done my residency in surgical oncology. And if you ask me today how much a particular investigation costs for the general category versus the paying category, I can tell you, I really don't know. I don't even know the cost of a complete blood count. And I'm telling you, I can assure you 90% of my colleagues in this hall also do not know the cost. So we don't know. We just advise the investigations. We tell our patients to go do this, and we don't know what we are advising, what it's costing our patient. So we all need to learn this, not now, but right from medical school. And we have to train healthcare personnel in understanding what value based outcomes are. When we look at certain tests, exciting tests like immunohistochemistry and finding out what subtype of sarcoma it is, and when we randomly go on ordering fish and RT-PCR, we have to understand that all this technology is not something that we have developed. And the cost of this technology is inbuilt into the tests that we order. So we have to evaluate and develop value-based pathways and optimally utilize other ancillary services like nutrition, like physiotherapy, which go a long way in adding value to the patient's cancer care. And of course, we know with evidence that integration of palliative care early on is very important. So this systematic review has shown that training physicians to provide high value, cost conscious care actually works. A small intervention like adding a pocket sized brochure with lab investigation prices resulted in 36% decrease in lab expenditure over 4 months. Just inserting antibiotic prescription guidelines in patients' charts resulted in 43% reduction in prescription. These are small things that we can try and we can do. When we look at developing technology for low resource settings, we have to know that it should meet an important clinical need, and we have to consider local environmental and cultural factors. We have to remember that sometimes electricity and refrigeration itself may be unreliable in low middle income countries. And this technology needs to be, low maintenance and low cost, and you should utilize all the existing systems that we have in place. So coming to surgery, because I'm a surgeon, how do we make a roadmap for value-based surgery? Surgical care actually accounts for 30% of the total healthcare expenditure of a patient in the multidisciplinary pathway. And surgeons are often at the forefront of adopting new technology. So, and we also maintain audits. We like to see where we went wrong, what we could have done better. And all this can be utilized for making the treatment of the cancer patient more value-based. We have to work as a team. We have to be open to peer review and to credentialing so that the surgery that we offer is standardized, it's value-based, and already early recovery outcomes and daycare surgery are being adopted in a big way in our country. To minimize the patient at the time that a surgical patient wastes in the hospital or spends in the hospital, we have to optimize our patients before getting them onto the table. And we can always utilize telehealth for post-discharge and follow-up, as we have seen in the COVID pandemic. This is a nice paper that I came across, and Bhavna is one of the authors on this paper, how we can adopt value-based care in systemic therapy. So the foremost thing that we should do is communicate regarding costs of the therapy to the patient so that we can detect if their finances are adequate to fund their treatment. Now, if the decision is well informed, it will lead to better asset management on the part of the patient and his family. It will increase the treatment compliance, and this will lead to better outcomes. They have suggested some strategies which have been touched upon by the previous speakers also: alternate dosing of drugs, rational pricing, how we can incorporate palliative care and patient-reported outcome measures, health technology assessment, how we identify and de-adopt interventions which do not have much value, and we re-examine the role of regulatory agencies. Just because something is approved by FDA yesterday doesn't mean that I should start prescribing it to my patient today. So we need to limit the delivery of low value, low quality care and decrease over-treatment. And we need to continue this conversation. Just defining the value and finding out the cost and decreasing over investigation and over treatment is not enough. We have to review what we have been doing. And this is a development that I didn't know. This is a national cancer database for cost and quality of life, which has been set up. And a website that I came across, the National Health System Cost Database for Indian. It is a tool for health policy makers and analysts who need information on unit costs of health services. So I think it's time we get online and visit this website, look at the resources that they have, the data collection tools, and familiarize ourselves with this. So the way forward, it starts with communication between the healthcare providers, between the patients and the government, how we utilize tools to estimate financial toxicity, We utilize the various schemes that are already present in the country, the PMJ and the other schemes. We should develop research by incorporating costs and other financial distress parameters, not only looking at progression-free survival or quality of life. And we have to develop value-based guidelines like we have done in the National Cancer Grid, where some guidelines are essential, that you cannot treat a cancer patient without those important steps, then some which are optimal and others which are optional. And we have to identify and avoid low-value practices. So value-based healthcare is meant to improve outcomes which matter most to patients. They don't only want to live longer, but also live better. But the development of high-value care involves identification and mitigation of financial toxicity. Discussions and interventions can keep happening between the directors of the hospitals and the stakeholders and the government, but these are time-consuming and these are tedious to implement. We need corresponding strategies aimed at individual patients who come to our outpatient clinic every day. This conversation is difficult, but it needs to start now. Thank you.